As pediatricians, we know far too well that the role of graft-versus-host disease strictly depends in our transplanted patient from the background disorder. So we know that inborn error of immunity or metabolic inborn error deserve transplant and do not benefit from any graft-versus-host disease. So for those patients, we will aim at a transplant that is free from acute and chronic GvHD at all time to try and prevent the acute and long-term GvHD and immunosuppression-related side effects. On the other hand, though, we have leukemias where we hope to exploit the graft versus leukemia effect, which is paralleled in our current understanding of the biology to graft versus host disease. So in some specific subsets of patients, specifically those with very resistant disease, it might be beneficial to induce some GvHD. And we know now we have data that show how that can improve the incidence of relapse after transplant and thus give way to a better long-term survival. The key question is how do we engineer a GvHD that is enough but not too much? And that's, I think, at the moment, still a lot of guesswork. So in the first instance, it would be great to be able to induce a GvHD, which we can control at the time when we need it. So I believe the first matter of research in this area is making sure that we have enough strategies to support the patient through GvHD and control GvHD as much and as long as we need to do, because it will be for quite a while still impossible exactly to engineer the level of GvHD that is useful but not dangerous. So I think especially in pediatrics, where there are yet a limited number of drugs that are licensed for the use of GvHD, for the treatment of it, it is paramount to continue invest in prospective studies that will show us which agent work best for the pediatric population of patients and how we can support our patients through the acute phase of GvHD. Thank you very much for your time.